Walking is one of the basic natural activities we perform every day as human beings. To walk, we use our feet and legs. Two of the main diseases that affect this beautiful natural gift are podoconiosis and lymphatic filariasis. Podoconiosis, non-filarial elephantiasis, is a non-infectious disease which is common among barefoot individuals who are in long-term contact with irritant red clay soil of volcanic origin. The disease is found where irritant soils have been generated by environmental conditions of high altitude, greater than 1,000 meters, and high annual rainfall, greater than 1,000 millimeters. The disease typically manifests itself between the ages of 10 and 30. Podoconiosis can be prevented by using foot hygiene, proper footwear, and covering the soil floors of a house by other materials. However, there is another similar but different disease resulting in elephantiasis, lymphatic filariasis. Lymphatic filariasis is an infectious disease caused by a species of filarial roundworms. Infection occurs when filarial parasites are transmitted to humans through mosquitoes. Infection is usually acquired in childhood, causing hidden damage to the lymphatic system. The prevention of lymphatic filariasis includes vector control and mass drug administration with combination of drugs for 5 consecutive years in waters where the disease is common. According to the nationwide integrated lymphatic filariasis and podoconiosis mapping result of 2013, 345 districts are endemic for podoconiosis, and 53 of them are co-endemic for both podoconiosis and lymphatic filariasis in Ethiopia. Podoconiosis is found in highland areas of tropical Africa, Central America, and Northwest India. Population-based surveys suggest a prevalence of 5 to 10% in barefoot populations living on irritant soil. Globally, 6 million podoconiosis cases are estimated in more than 32 countries. An estimated 120 million people in tropical and subtropical areas of the world are infected with lymphatic filariasis. Of these, almost 25 million men have genital disease, most commonly hydrocele, and almost 15 million, mostly women, have lymphedema or elephantiasis of the leg. Approximately 66% of those at risk of infection live in the WHO Southeast Asia region and 33% in the Africa region. In Ethiopia, 112 districts are endemic for lymphatic filariasis. The common outcome of both podoconiosis and lymphatic filariasis is lymphedema. Patients with podoconiosis and lymphatic filariasis are not only physically disabled, but suffer mental, social, and financial losses, contributing to stigma and poverty. If proper work is done in creating awareness, the diseases are completely preventable, and if treated on time, a patient can manage to cope with the consequences of the disease. In order to assess the effectiveness of the lymphedema treatment, benchmark information is collected during the first visit. When new patients are registered, they collect their personal information, clinical stage, presence of moss, presence of wounds or entry lesions, and stage. Measure the circumference of the largest point of swelling below the knee with a flexible measuring tape. When diagnosing a patient of lymphedema, differentiate if it is caused by podoconiosis or lymphatic filariasis. To do that, observe the swelling. The swelling of podoconiosis starts in the feet and proceeds up the leg, while that of lymphatic filariasis starts at the groin and proceeds down the leg. In addition, lymphatic filariasis causes swelling in other parts of the body, like breasts, arms, and scrotum. The essential clinical package of lymphedema management includes 5 components that are the same for LF and PODO patients. These components are recommended for lymphedema patients at different stages. In the video, we will cover the components with patients of lymphedema with different stages. Following the basic rules of hygiene as shown next is advisable. Wash both limbs with clean water and body soap. Wash thoroughly, applying soap from the knee down. Take extra care to wash gently between the toes and folds using a clean cotton cloth or gauze. Rinse the limb with clean water. Repeat the process of washing with soap and rinsing until the rinse water runs clean. Soak the feet for 15 minutes with 8 liters of water and 2 cups of dilute bleach, or 4 liters of water with 1 cup of dilute bleach, depending if necessary. Diluted vinegar can be used in the place of diluted bleach. If possible, potassium permanganate is advised. If the patient has open wounds, please advise them not to use antiseptics like bleach. Instead, only use water and soap. Gently dry the skin well using a clean towel or wait for it to dry by itself. Make sure that the skin between the toes and skin folds are carefully dried. After washing and drying the legs and feet, it is essential to rub the skin with ointments like Whitefield or petroleum jelly. It keeps the skin soft and flexible and acts as a barrier to soil particles that cause podoconiosis and the bacterial and fungal infections. Lymphedema predisposes to wounds. It is important to clearly follow the following steps as often as needed to care for wounds. Wash hands and wear clean gloves before treating the wound. Have an assistant to help with the treatment, as touching other materials after contact with the wound would spread an infection. Clean the wound with salted water or saline solution. The wound should be cleaned from center to outward. Caring not to make the wound bleed, gently remove any yellow or brown tissue from the base of the wound. Assess the wound by measuring, smelling, and examining the look. Check for infection. If infection is present, it is important to control it to stop spreading to the rest of the body. To treat the infection, rub the edge of the wound with zinc oxide to protect the healthy skin, then apply honey to the wound. Use gauze around the wound to hold the honey and zinc oxide in place. If honey is unavailable, betadine solution or acetic acid solution may be used. Add antifungal creams to prevent fungal infections in deep folds and between toes. If infection is thought to have been spread beyond the wound, the patient must be referred for systemic antibiotics. After the proper treatment, it is important to wear appropriate footwear. It will protect the feet from injury that can lead to acute attack and other infections. The footwear should be comfortable, should not be tight, should allow air to circulate around the foot, and should have a very low heel. If necessary, custom-made footwear should be made for the patient. Socks and shoes should definitely be kept clean every time. If they become dirty, they should be washed appropriately. Patients should be encouraged to keep moving. Frequent exercise of the affected limb will bring relief and can help reduce swelling. The exercise can be done anywhere and at any time except for during acute attacks. The affected limbs should be raised. Elevation is important to prevent the accumulation of fluid in the affected parts of the body. When sitting, the affected leg should be raised to hip level on a stool or something similar. When lying down, the leg should be elevated by placing a support under the mattress. Pillows can be placed below the leg to get more comfort. During patient counseling, it is important to note that the health professional should counsel the patient on the physical and psychological effects of the disease. Patients of lymphedema are exposed to depression and stress due to stigma and other social and economical problems related to the disease. During counseling, discussing the nature of the disease and how it affects the patient and advising and encouraging on how to deal with the social and physical effects of the disease boosts the psychological strength of the patient. For the first 3 months, patients get treatment once a month. During follow-up visits at the clinic or at the patient's home, health workers should be keen to detect entry lesions, remind patients and their family of the basic management techniques, and emphasize prevention and early care. After the first treatment, patients should be trained on how to treat themselves at home, and the necessary treatment supplies should be offered to the patients. After 3 months, patients should be followed up every 12 months to address any issues and ensure compliance with the basic self-care routine. Bandaging is highly effective in reducing swelling in most patients with podoconiosis. The leg should be bandaged from the toes towards the knee, ideally when the leg is elevated. The leg should be wrapped using a V-shaped design and then bandaging continued in a spiral up the leg to 5 centimeters above the upper limit of swelling. Patients with big folded skins, foams can be used to fill on the cavities to create the desired pressure. Patients of podoconiosis who need to remove nodules and patients with deep fungal infection manifested as additional lumps should be referred to a surgeon for minor surgery or biopsy test. Patients with filariasis who are positive by antigen test or have microfilariemia can receive individual antifilarial drug treatments to eliminate microfilariae. They can be treated with a single dose of a combination of albendazole 400 milligrams with ivermectin 150 to 200 mg per kilogram. An acute attack is characterized by the recurrent infection. It can be identified with reddened, hot, and tender limbs combined with fever and chills. Lymphedema patients and their families should follow the following measures to care for affected body parts during acute attacks. During an acute attack, to get pain relief, soak the affected limb with cold water or apply a clean cloth soaked in cold water. Paracetamol can be used to reduce fever. The lymphedema patient should drink plenty of water. The patient should rest, elevating the affected part of the body as comfortably as possible. Antibiotics, usually penicillin, should be used as treatment if pain and fever are not reduced after 24 hours or if shivering and confusion arises. During acute attack, a patient shouldn't exercise, put anything warm or hot on the skin, cut the skin, bandage the leg, rub anything on the skin other than advised by a health professional, or use scarification. To completely eliminate these diseases in Ethiopia, focusing on the prevention and treatment of the already affected patients is the key. Then, we can guarantee the safety of the future generations from these diseases.